Well, good evening, folks, and welcome to tonight's Men's Health webinar. Tonight, we're talking about the signs, symptoms, and treatment options for erectile dysfunction and male stress urinary incontinence. So if those conditions are not what you came here to see, you might be in the wrong presentation. We are joined by two expert urologists. They are passionate educators, passionate about men's health, and very talented clinically. We have Dr. Eugene Park and Dr. Nathan Bockholt. Tonight, they're going to cover these conditions, go over what causes them and what the latest treatment options are. This is somewhat interactive in that you're encouraged to ask questions. Now, to do that, you can, anytime during the presentation, encourage you to tap the screen of your mobile device or move the mouse on your laptop or desktop. You're going to see a toolbar pop up in the Zoom window. It says chat. So click on that tool, type your question in, hit submit, and then we will answer those questions at the conclusion of the presentation. Now, without further delay, I'd like to hand it over to Dr. Eugene Park.
Hello, thank you for spending your evening with us. I'm Eugene Park. I'm one of the urologists in Sioux Falls. I'm going to talk a little bit about ED tonight. I don't know if you guys have your smartphones out, but this is just a QR code, and it's a little bit of information to talk about what we're going over tonight. So a little bit about me. I practice out of Sioux Falls, South Dakota. That's our main base. I also go out to Hendricks Community Hospital. I go to Ortonville Clinic up in Minnesota. I did my medical school in the University of Illinois. I did my residency out in Nebraska, Omaha, Nebraska. It says I specialize in sexual dysfunction. I wouldn't call it specialize. I have kind of an interest in it. But at our practice, we kind of do a little bit of everything down in Sioux Falls. So I was born in Rockford, Illinois. Rockford is famous for the band Cheap Trick, even though they say they're from Chicago. If you guys remember the movie A League of Their Own, the Rockford Peaches, that was my hometown. It was also voted, Rockford also voted Taco Bell as their #1 Mexican restaurant. That made national news. I always put that slide up. I'm really proud of it. Hobbies that I like. I'm a Leo. I like traveling. I like fishing, photography, dogs. I like to barbecue. Here's a couple pictures of my barbecue adventures. If you look in the bottom right corner, that's my new toy. It's my new offset smoker. I like photography. I kind of dabble in amateur photography. These are some of my fish in the past few years here. These are my dogs. I've got a little petting zoo at home, it seems. I got 4 little dogs here. One of my newer hobbies, I've been making costumes at home for Halloween. These are my last 2 costumes at home. I build these. Probably have too much time or I don't sleep enough. All right. So the real presentation, learning about erectile dysfunction. ED, what is it? How common is it? So how do we define ED? ED is the inability to achieve or maintain an erection firm enough to have sexual intercourse. It happens in about 1 in 5 American men, 20 years or older. So that's a fair number of people. If you think about it, it's about 20% there. More than half of men over 40 have some degree of ED. Affects approximately 39 million American men. So if it's something you're struggling with, you're not alone. So the erection process. So what actually happens during an erection? So I tell people an erection is essentially a blood flow event. So with arousal, the nerves around the penis become activated, the muscles relax, and it allows blood to flow into the penis. There's a tissue in there. It's kind of a spongy tissue that fills up with blood and engorges, and there is a kind of a firm sheath on the outside that gives the penis its rigidity. The erection compresses the vein so the blood can't leave the penis, enabling the penis to remain erect. So these 2 pictures show flaccid and erect, and what they're showing is the picture on the left doesn't have the blood engorgement. The picture on the right with the erect penis is engorged with blood. It's a little bit of a blown up picture here. So the causes of ED, the top three physical causes are vascular issues, diabetic issues, and medication. ED can also be a result of prostate cancer treatment. If you're visiting us in urology practice, you'll probably see people with prostate cancer. And if you've ever talked to people with prostate cancer, one of the common things they talk about is the loss of erections after something like a prostate cancer surgery. ED can actually be a precursor to diabetes, or the signs of it can be precursors to diabetes and heart disease. So I'll go into those in a little bit here. ED can have a broad negative impact on the health related quality of life, obviously. So, ED and diabetes. So, according to the 2015 census data, 15.3 million men in the United States have diabetes. Patients with diabetes and ED are less responsive to oral treatments for their ED. In men with diabetes, ED is more severe and associated with a decreased quality of life. In some patients, ED can be the presenting symptom of diabetes. So why is there an association? So diabetes is typically a disease of vasculature and nerves. 60 to 70% of people with diabetes have nerve damage. It's one of the reasons diabetics have to watch their feet carefully. They just don't have the sensation in their feet. They get an injury they may not notice, and it can become a bad infection. Diabetes also is a vascular issue. It accelerates the damage to the inner lining of small arteries. And so ED pills require stimulation of the nerves and blood vessels. So if both of those are damaged due to diabetes, the pills may not be as effective. Factors that may increase ED in men with diabetes: advancing age, diabetic duration, poor glycemic control, vascular disease, diuretic treatment or water pills, heart disease. It kind of transitions into the next slide. So, erectile dysfunction and heart disease. We talked about ED being a precursor to heart disease. So, what's the link there? So, symptoms of heart disease may actually develop within 2 to 3 years of erectile dysfunction. ED is an independent risk factor for the future or for future heart-related events. The severity of ED is correlated with the extent of coronary artery disease. ED precedes coronary artery disease symptoms in almost 70% of cases. Yeah, we talked about that. So the reason we talked about how the arteries can be damaged from if the arteries are damaged, it can cause a problem. And so if you think about it, the arteries that go to the penis, they're smaller than those that go to the heart. And so if blockage is going to happen, it's going to happen in the smaller vessels first. And so at 50% obstruction, the penile artery may cause symptoms of erectile dysfunction. And this slide just kind of gives you a relative idea, a relative size of the arteries. So it's easier to clog up a smaller artery than it is to clog up a larger artery, which is why ED may happen before coronary artery disease. And this is just to give you an idea. This is the size of the internal carotid artery, and this is the diameter of the femoral artery, which goes down to your legs. Risk reduction. So you can reduce your risk of erectile dysfunction by improving your heart health. Um, Healthy lifestyle choices are a good way to start with diet, exercise, and physical activity, weight loss. Quitting smoking is a huge deal. Smoking is notorious for causing damage to blood vessels. Reducing stress is always a good thing. So erectile dysfunction and prostate cancer treatment. We talked a little bit about this earlier. So the nerves and the blood vessels that supply blood to the penis for an erection lie very close to the prostate. And invariably, when you do a prostate cancer surgery, those are going to get affected. Even if you spare the nerves and the vessels, they're going to get affected to some degree. Um, so if you look at this picture here, this is kind of a cross section. Up here is going to be the head. Down here is going to be your feet. This is the bladder. This is your prostate. When we do the surgery, we kind of cut here and we cut here, and we sew the urethra or the urine channel back to the bladder here. And this is just a picture of the prostate being gone. But these are the nerves, the neurovascular bundles, the nerves and vessels that we're talking about, that help facilitate an erection. So during the surgery, these can get damaged, essentially. I've got some construction going on outside. I apologize if you hear that. This is just a little bit of an enlarged view of that, but it's these guys that can get damaged during the surgery, which is why you hear people complain about after having prostate cancer surgery. It's those neurovascular bundles that get damaged. The sexual dysfunction after prostate cancer treatment. After a radical prostatectomy, 25 to 75% of men will have some form of sexual dysfunction. Even with the nerve-sparing robotic surgery, ED may persist a year or more after surgery. Sexual dysfunction after radiation affects about 50% of men. So it affects both surgery and radiation. So the treatment options for ED. The treatment options, if you talk to any of us in our office, we'll go over several options for you. The options start with oral pills. Everyone, I think, at this point is familiar with Viagra and Cialis. There is something called injection therapy. There are medicines we can actually teach people to inject directly into the side of the penis that will help give erections. There's something called a vacuum erection device, which is kind of a negative pressure device that helps give an erection. There are suppository type tablets that you can put into the penis, actually, into the urinary channel to help facilitate an erection. And then there's something called the penile implant, which we'll go over in a bit here. But the penile implant is an actual device that we can put into people surgically to help get them erections. So the oral medications, they're called PDE5 inhibitors. How do they work? How effective are they? Common side effects, cautions. Little light bulb down there says almost half of some men with ED who try oral medications give up on the pills or they stop working. Men with diabetes are up to two times more likely to move on to other treatments. So the medications are designed to increase the blood flow to the penis. Effective in approximately 60 to 80% of cases. Efficacy can be affected by food. When we give out prescriptions for generic Viagra, a lot of times we'll tell you it works a little bit better on an empty stomach. Common side effects: headaches, facial flushing, upset stomach. You should talk to your doctor if you're on something called alpha blocker therapy for blood pressure or your prostate, or if you're taking something called nitrates for your heart. The combination of those can drop your blood pressure. So we have to be careful in people taking those types of medications. The injection medication. So the injection is actually a really effective way of getting an erection. You have to, there are different combinations of drugs that we can give you. There are single agent units. There's something called trimix or quadmix where you put a couple different medications in. But the idea is you inject the medication directly into the penis and an erection may develop within 5 to 20 minutes. How effective is it? Despite success rate, approximately 40% of men will discontinue the therapy, typically within 6 months. Most common side effects: penile pain, prolonged erection. On all the commercials, you always hear about erections lasting more than 4 hours. That's something called a priapism, but that can happen if you give yourself too much of this medication. Scar tissue can develop. You can develop something called a hematoma or a blood blister under the skin. Most common reasons for discontinuation: failed erections, pain, dislike of injections. I often tell people it's actually a very good medicine. It's just there are some people who they just can't wrap their heads over giving themselves an injection, but it's actually a very reasonable option. The vacuum erection device. So this is that negative pressure system we talked about. How does it work? So you place a unit over the penis, and it basically creates a suction to help draw blood into the penis. Once you do that, you have to place a constricting band at the base of the penis to try to maintain that blood in the system. How effective is it? Patient satisfaction rates range from 68 to 80%. Most common side effects: blocked ejaculation, bruising, discomfort, pain, penile numbness, or coldness. Most common reasons for discontinuation: inability to achieve and maintain a full erection, pain, or discomfort. The urethral suppositories, I'm not going to go over this one too much. This is one I don't really use very much. In my practice, at least, I've never found them to be very effective. But um, these are medications you can actually place directly into the urethra or the urine channel, and it kind of dissolves, and the medications go into the body of the penis. The idea is to get an erection within 5 to 10 minutes. How effective is it? Success rates are reported at 40 to 66%. Most common side effects: genital pain, minor urethral bleeding or spotting, low blood pressure, dizziness. The most common reason for discontinuation: insufficient erections, urethral pain and burning, or switch to another ED therapy, natural return of erections. So it's pretty, if you look at the little light bulb down there, unopened suppositories must be refrigerated. 75% dropout rate of post prostatectomy patients within 15 months. So I'll give it out occasionally on guys who are really interested, but as far as like I said, in my experience, I haven't been terribly impressed by the suppositories. The penile implant. So this is kind of the heart of the talk here. You'll see here, this is kind of a diagram right here on what we're talking about. It's a mechanical device that we can actually give people surgically. Um, how does it work? So we actually place these inside the body. So these guys will actually fill up the cylinders of the penis where the blood normally goes. We place something called a reservoir filled with fluid inside the body, and it's all connected together with a pump. So what happens is when you want to have an erection, this pump, which is hidden in the scrotum, you'll start pumping it. It will draw fluid from the reservoir and fill these cylinders, and it's essentially mimicking engorgement of the bodies of the penis. And so how effective is it? 98% of patients reported erections to be excellent or satisfactory. Um, Most common side effects of this: postoperative and genital pain or infection, mechanical malfunction. It is a device. Like any device, it can wear down. There are parts that can break. But at 7 years, 94% are still fully working. There are different types of devices. I don't know if I've ever really seen a two-piece, but the three-piece is the one that most people are familiar with. It's the one that has the reservoir, the pump, and the cylinders here. The other one I think people know if they've done their research is the malleable. The malleable are these two rods that we can put in. It doesn't have the pump, it doesn't have the reservoir, and it's made of a material that is bendable. So when you need to have an erection, you physically take the shaft of the penis and you put it up. When you're done, you physically pull it down. One of the reasons to do the malleable over the three-piece has to do with the fewer number of parts. If you're worried about mechanical failure, the other thing to consider is some people will consider it if they figure there's fewer pieces to get infected. So if there's some reason we're worried that you might be someone who could get infections, we might consider the malleable. But I think most people, when they think about the prosthetic, they're thinking about the three-piece device. So the three-piece, and that's just another picture. Surprisingly, if you didn't know this, the implants have actually been in clinical use for over 45 years. More than 500,000 men have received an implant. So the device done by or created by Boston Scientific has an antibiotic coating called inhibizone. It's kind of baked. This antibiotic is baked into the the actual device itself. The biggest fear for us as surgeons is we always worry about this device getting infected. Any kind of foreign body in the body can get infected. I think nationally they talk about the rates of infection being at about 2 to 3%. But this inhibizone is designed to kind of kill bacteria over a series of time to try to prevent bacteria from setting in, so that infection can't go. So why choose the implant or the Boston Scientific implant? Number one is that inhibizone. Number two, the reason people pick the implant or this implant is that it mimics, it's the closest to mimic natural physiology. So when you have an erection, you look like you have a natural erection. When you don't want an erection, you can deflate the device and you can look flaccid. So people do appreciate that. They appreciate the fact that it's basically hidden. People don't have to necessarily know about it. And I think that's important. People obviously are self-conscious about things like this, and I think that certainly helps guys from a psychological standpoint. What to expect for the procedure? It's usually done as an outpatient. Everyone's a little bit different about what they do post-operatively. Some people will keep people overnight. I try to get people out the same day, but that's just kind of a surgeon preference. There are different ways to implant it. Some people will go through the scrotum or underneath the scrotum. I do something called an infrapubic approach, meaning I just make one incision above the pubic bone or the pelvic bone. Through that one incision, I can do the whole thing. Generally, it'll take a few days to return to your regular routine or light activity. Activation of the device, it's anywhere between 4 and 6 weeks. And so that again is kind of surgeon preference. I've seen people who will activate in 3 weeks. I've seen people activate in 6. I've been pushing more towards the 6 weeks. I've just kind of decided I'd like people to be more healed and all the bruising and the swelling to be gone before they start using it. But it's kind of a surgeon preference there too. Cost and coverage. Insurance coverage for ED treatment varies. I'm sure most of us at this point realize every plan is a little bit different and they're all very complicated. But coverage is usually available. We just kind of have to talk to you about what's available or what your plan will cover and things like that. They mentioned down below, don't let cost be a barrier. Treatment can be affordable. So if you just talk to us, we can kind of work with you as far as how the cost of it goes. We can certainly work with you and the company for financial assistance options and things like that. So the benefits of the implant: 97% patient satisfaction, 98% partner satisfaction with a 3-piece penile implant. Clinically proven to reduce the risk of infection, typically affordable, long-lasting, permanent concealed solutions, durable. 89% are still in use after 10 years. We talked a little bit about the how it kind of mimics the natural physiology. It's designed to maintain a natural appearance in the erect and flaccid state. Typically doesn't interfere with ejaculation or orgasm. It's spontaneous, so you can have sex when the mood strikes. A little more about the possible risks. Anytime you do a surgery, there's always going to be potential risks. Not all patients are candidates for an implant. If you're interested, you come to talk to us. We would certainly go over all the details, but I think some of the risks we go over: risk of bleeding, infection. If you decide to do this procedure, I tell people this is kind of like crossing a point of no return. You can't go back to the previous treatments once you decide to do surgery. So if you're at a point where you want to talk about surgery, you can't go back to the pills. You can't go back to the vacuum device or the injection. So this is kind of the final solution. There can be mechanical failure of the implant, which can require revision. I mean, the pump could break or something could leak. I've heard of people who've been in car accidents and the reservoir burst. So the pieces can be traded out, but you might have to have surgery for that. People with diabetes, spinal cord injuries, open sores, there are increased risk of an infection. If you do get an infection, there's a good chance we might have to remove the implant. And like I said, the risk of infection, somewhere about 3% nationally. So, kind of in summary, ED is a common problem, may be associated with other conditions. There's a variety of treatment options available. The implant is a good option, could offer a long and lasting and satisfactory solution. There is this website, edcure.org. If you guys are interested, that'll give you some more information there. These are just the references. So it says questions, but I think we decided we'll do questions at the end here. So I'm
So,
going to pass this over to Dr. Bockholt. See here if I can figure this out. There we go. Did that work?
yep,
Here, you hear me all right?
yep, sound good.
So yeah, I see some really good questions coming through. We want to get to those at the end. Some anatomical questions, some other questions, but being a urologist, 40% of all male cancer is urologic. So Dr. Park and myself deal with a lot of cancer, and unfortunately, one of the main cancers is prostate cancer. So I work in Sioux Falls, South Dakota for the majority of the time, and then my outreach clinic is up in the middle of South Dakota and Huron. Mainly do a lot of cancer, but also inevitably you're going to see um, more men than women. So you have to be well versed in dealing with men's health, as well as, like we talked about this evening, erectile dysfunction and dealing with cancer, especially prostate cancer. We deal a lot with people that have prostate surgery and the ramifications of having that type of surgery. And one of those side effects sometimes is incontinence. Um, I grew up in Sioux Falls, South Dakota. Well, actually in Sioux City, but I lived probably more of my life here in Sioux Falls. Went to med school in South Dakota, was down in Iowa, and then out in UCLA for a year, and then practicing here for the last 10 years. But what I'm going to mainly discuss is urinary incontinence, as well as some of the risk factors, as well as some of the treatment options. So stress incontinence is basically when you have intra-abdominal pressure that exceeds your outlet resistance. And in men, the prostate provides a lot of outlet resistance. So in gentlemen that end up having prostate surgery, whether it's prostate removal or even other types of procedures within the prostate, sometimes can make it so they can't control their urine. And so when they cough, lift, sneeze, stand, bend over to get out of the car, lift something heavy. Anytime that resistance is over exceeded by whatever they just did, they'll have some incontinence. So this affects many men over throughout the world and thousands of men in the United States. Just a quick anatomical picture here. The way we're made, the kidneys filter all your blood and the byproducts urine, and the urine goes down to the bladder, which simply just acts as a storage vesicle. And the urethra goes through the prostate, out the penis to the very end. So any issue throughout that channel can affect how a guy empties his bladder. And since the prostate provides a lot of resistance, men that have had a prostate removal, that sphincter muscle that surrounds the urethra, that the strength of that really impacts how a man can control his urinary flow or prevent the flow after a surgery. The most common cause of stress incontinence in men is classically the prostatectomy. The majority of these surgeries are done now robotically, but with over 300,000 new cases of prostate cancer diagnosed, the prevalence is about 1 in 8. So if you live long enough, there's a good chance that you're going to have prostate cancer. Around 10% of all men that get prostate cancer are going to die from it, which means about 90% of men are not going to die from it. But out of all those men that are getting diagnosed with prostate cancer, around 40% of those men are going to decide on getting their prostate removed as hopefully a curative option. But there's other issues that can result in incontinence. There's neurologic issues. People have had radiation or pelvic trauma, previous urethral surgery. There's certain types of surgeries men can get even when they're younger that can affect their continence. And before cataract surgery, the resection of the prostate to help men pee that used to be one of the most common surgeries in the United States. And even there is a rare instance, but some men can have permanent incontinence after that procedure. There's no doubt that the men that Dr. Park and I take care of that have incontinence really affects their quality of life and starts to influence what type of activities they do or don't do. So inevitably, people that are going to have their quality of life impacted and have to avoid certain activities that they used to enjoy are going to have a higher rate of depression and even anxiety of going out in public. So like I said before, thousands of prostatectomies are done. There's a certain percentage of men that have persistent leakage, and it depends on their level of comfort with that leakage if they want to entertain having intervention for it. There are some men that may feel like um, the options are very invasive or are going to have a similar recovery as to their prostate removal. So those are all discussions that we should have in the office to kind of put those anxieties at ease. The prostate's that organ that sits between the bladder and the urethra actually goes through the prostate. So when you do a prostate removal, you have to dissect the prostate off of the bladder, dissect the prostate off the urethra. And so when that organ is out, you have to sew the bladder back down to the urethra. Men have a catheter for about 10 to 12 days. And then afterwards, there is there's a process where I don't know how these got in here. See here. There's a process where you can go through some rehabilitation exercises that helps the patient get their continence back up to speed. Let's see here. When I go to this, let's do that. So some options. Physical therapy, either with a dedicated physical therapist and or doing what's called Kegel exercises, where you strengthen that sphincter muscle, almost similar to as if you were going to urinate and stop your stream, doing certain sets or a number of those exercises each day for a number of days during the week can actually strengthen that muscle. And over time, what you're going for is that your subconscious actually helps strengthen and contract that muscle. So before you cough, lift, sneeze, stand, or bend, you're actually going to prevent the leakage from occurring. There's some things called biofeedback where you can actually watch the amplitude of your sphincter. And after several sessions in the office, you can actually have a better coordination between the brain and the sphincter where you can increase the amplitude of your sphincter muscle to strengthen it to prevent incontinence episodes. And there's a lot of patients that are trying to cope with this by wearing pads, depends, catheters. There's special, almost like a cup that you would wear in sports that can collect the urine. So then it inevitably affects the type of clothes that you wear and the things that you're doing. One of the main long-term stress urinary incontinence treatments that we can do is we put in a urethral sling called an advanced sling. And the patient selection is key for this, where the typical patient that really has a great response is somebody that goes through about 2 or 3 pads a day. If they urinate, they can stop their stream. And the way that we evaluate the patient is everybody gets a cystoscopy or what's called a scope down the urethra through the into the bladder, and you want to make sure that there's no scar. Sometimes we'll watch how that sphincter can close upon telling the patient to close their sphincter. And the way I do it is I'll fill up the bladder and then I'll have the patient void. And if they can really stop their stream and they're only going through a few pads a day, they tend to do really well from this procedure. Uh, Here's a kind of a schematic of your pelvis. The incision is actually behind the scrotum, between the scrotum and the anus, because the urethra runs right along that area. You make a small incision and you dissect out the urethra and you dissect the muscle off of the urethra and you make two little tiny stab incisions right underneath the muscles that can move your legs in and out, because that's where these foramen or holes are in your pelvis, and you pass a little passer through these holes and you grab one side of this little mesh, little skinny piece of mesh, and you put the trocar through the other side, and when you pull that up, it actually elevates the urethra and suspends the urethra. And at the time of the surgery, we use a little scope and we watch inside the urethra. And as we tighten up that hammock or that piece of mesh, we watch the urethra come together, or coaptate is what we call it. And we want that just tight enough where we can help them be dry, but also not inhibit them from emptying their bladder. So the results are very good as far as if you have good patient selection, the vast majority of those men are going to be happy that they're drier. For men that have, I'd say, more substantial incontinence, where they're going through numerous pads or depends every day, they have trouble stopping their stream, especially in men that have had previous radiation or are very overweight or had really aggressive cancer where surgery had to be more aggressive. It's going to take something where you can actually physically close off the urethra. And this device is called an artificial urinary sphincter. It's been out for several years, decades, a matter of fact. And what this ends up, you make a similar incision over the urethra, but instead of putting a little piece of mesh to suspend the urethra, you actually dissect completely around the urethra and you put what's called a cuff. And that cuff is filled with fluid. And kind of like the penile prosthetic that Dr. Park discussed, you have three pieces. You have a reservoir up kind of near the bladder behind the pubic bone. You have a pump in the scrotum, and you have a cuff around the urethra. That cuff is closed the majority of your day. And when you want to pee or void, you pump this, you close the pump or pump up the pump in the scrotum right next to the testicle. And what it does is it moves fluid from the cuff up to the reservoir. And that cuff opens and you're able to void. And over the next few minutes, because it's pressurized, that cuff closes again around the urethra so you remain dry. So it's something where you can still mimic the true, you get the urge to go when your bladder's full. You hit the pump in the scrotum and squeeze that just a few times. The cuff opens, you pee like normal, and then it simply activates or compresses again around the urethra. And here's just a little schematic. So here's a picture of the anatomy. You have the pump that you're squeezing in the scrotum. It's moving fluid from the cuff up to that reservoir. And then over time, the reservoir puts the fluid right back into that cuff. So there's nothing else that you need to end up doing. A quick mention about the sling. Almost all of those are done as an outpatient visit. About half of the men don't even go home with the catheter. Some guys need a catheter for about a day. Very rare will somebody end up requiring a catheter for about 1 week. I've yet to see somebody that had permanent obstruction from putting the sling in. Very low risk of infection, very low risk of bleeding. Putting in the sphincter, just like the penile prosthetic, you're actually dealing with the device, but the average lifespan is several years. So failure is very rare. Again, very low risk of infection, very low risk of bleeding. you want to pick the right size cuff for the size of your urethra. And we take a measurement multiple times to make sure that we're putting the right cuff in for that patient's urethra. Sometimes surgery is done just a little bit different for how thick the tissue is around the urethra, depending on if somebody's had radiation before or not. And most of those patients can go home in the same day. Sometimes we'll leave a catheter just for a day, and we actually deactivate that cuff for about 6 weeks or so to allow that cuff to really heal in place. Just like the penile prosthetic, we bring the patient into clinic and we activate that cuff, and we teach you how to not only activate it as well as deactivate it, but ideally we want to be involved with a phone call of at least if you had to deactivate that device. From from the numbers of patients, just like we talked about satisfaction with the sling, if we put in an artificial urinary sphincter, the number of patients, it all comes down to, are the risks low, are the successes high, and in the end, are patients happy that they had the sphincter put in, and would they actually recommend somebody in a similar situation also consider having the sphincter? Just like the sling, anybody that gets a sphincter put in, we also evaluate that patient in the office with a scope, as well as go over the risks and benefits. The number of sphincters that are still working a number of years after surgery is very high. So in the end, these are discussions that we have in the office. If the vast majority of the men that are getting prostate surgery that leads to incontinence, these are guys over 65. A lot of them are Medicare. These are covered with for insurance. Um, the patient testimonials are very good. Um, I am somewhat of a late adopter. I want to make sure that things that are specially new work very well, but the sling, as well as the sphincter, as well as the penile prosthetic, these things have been around decades, and um, I think the testimonies of patients that have had them done would definitely support it. So, Mike, we probably let's open it up to some questions.
So I think the first question is a good one for both of you. Now, whether it's a penile implant, artificial urinary sphincter, do implants come in different sizes?
As far as the penile implants, yes. Everybody's size is different. It's not just a one size fits all type thing. We try very hard to give you a device that fills the inside of the body of the penis properly. Because if you go too big, it'll try to work its way out of the body. And if it's too small, it won't. It'll kind of move around and slide around and not give you a good result. So, yes, there are different sizes, but we make that determination during the surgery.
Hmm.
And for the AUS, are there different sizes?
Yeah, we do. The sling it's the same size because you don't circumferentially dissect around the urethra. You're just simply supporting up the urethra, and you can kind of trim the excess as you pull it through those little openings. Whereas the sphincter, we do measure the size of the urethra, and usually they only vary by about a centimeter or so. And we try to put the correct size in where you're providing just enough compression to prevent leakage, but not too much, where you would put too much force on the urethra and the device could erode through the urethra.
Thank you. Now, if somebody gets an implant, will that allow them to continue ejaculating?
If you haven't had something like prostate cancer surgery, yes, it should not impact. It should not impact that.
So along those lines, says had prostate cancer surgery 3 years ago, can't get an erection, but can still climax through masturbation. It's discharge, not semen. What is this? So what is the discharge that is happening post prostatectomy?
Uh,
Hmm.
I had to guess it might actually be urine. because theoretically we disconnect all those structures that created fluid and all that stuff during
Yeah.
surgery. So that would be
Yeah.
my
And there,
guess.
you have these tiny little glands in the urethra called the
Mhm.
Latreille glands. They have tiny bit of fluid. Um, what we tried to explain to patients too at the before their prostate surgery is that you're made with like four different nerve sets: the erection nerves, the orgasm nerves, the emission nerves, um, and the sensation nerves. They're all different nerve sets. So, like what Dr. Park was saying, when the prostate's out, you don't really have the fluid from the prostate or the seminal vesicles coming anymore. Your testicles still make testosterone, but the sperm don't make it into the urethra anymore. But if the prostate's out and you spare the nerves, you still can have sensory or orgasm.
Connecting those questions. So if somebody um, is having that discharge with ejaculation, if they get the penile implant, will they continue to have the same discharge at climax?
Um, that's a good question. I don't think the implant would actually affect that process. So it's possible.
Yeah.
Um, because the implant just kind of gives you the physical erection. It doesn't really change anything as far as that ejaculatory response, because there's muscles that contract and things like that that force the fluid to evacuate. So that may not change. But I guess I don't know the answer officially, but that would be my best guess.
And now, for those patients who've gone through prostate cancer treatment, and this particular one has gone through 6 chemo treatments, and now in a monthly check-in phase. So, if they're experiencing ED incontinence, or I think the question is generally, at this point, what do they start with? When do they start treating things, and what modalities should they try first?
Are we talking? I'm assuming we're talking about ED and incontinence.
Yes.
Okay. I would consider doing a penile implant as soon as 3 months, assuming everything is healed. That's the earliest I would consider. I don't think most people are ready at 3 months. Um, Partly psychologically, they've just been through a big surgery, or they're still having leakage, or they're still kind of recovering in general. Um, I would say I think a year or so is a pretty reasonable time when most people are starting to think about, hey, I'd like to have something, because at that point they've kind of gone through the options like the pills and the injections and the vacuum device. Some of that also is dependent on your insurance. Some insurances actually require you to go through a few options before we even consider the implant. Um, but if you're talking about when is the soonest I would consider implanting, 3 months. I like people to be at least 3 months healed for
Yeah.
implant.
And in somebody who's had chemotherapy, we like to wait probably at least 5, 6 weeks after chemotherapy just to improve healing and decrease the risk of infection.
Uh, Post prostate cancer treatment, do you give patients pills or any other thing to help with blood flow therapeutically, or is the only time pills are used is for erectile dysfunction?
I will give people. I don't do it as much as I used to. There was this concept of penile rehab that people used to do, where they'd give, especially when the medicines became generic, it became much cheaper. We'd give out these medicines to encourage blood flow. I don't know. Maybe Dr. Bockholt will have a different opinion. I don't know if I necessarily felt like that made a huge difference, but I think some people still do it, and it's not an unreasonable thing to try.
I think what we are trying to do is to do something. Just there's been just a little data of putting a patient on some medicine about 3 times a week and using a VED about every day. That had just a little bit of promise, but I think that if something was truly superior out there for the penile rehabilitation after surgery, everybody would be doing the same regimen. But I just think the fact that there's so many different ways to go about it, it means that not one is superior.
Yeah, I'd agree with that.
So we had some pre-submitted questions, and one is about So pills that can be found online and at gas stations. And the question is, are these safe? And are these the same as the things that I would get from a doctor's office?
Hmm.
This is the a lot of people ask about supplements and things like that. This is what I tell people. I I'm not someone who doesn't think that these medicines can't work. I'm sure there are some that do work. My issue is when you call something a supplement, it's no longer regulated, and it's a safety issue. We had a family doctor visit us one time, and he kind of has a big interest in supplements and things like that. And he talked about how the rate of liver transplants in this country over the last 30 years has gone up like 3 times or something like that. And it kind of coincides with the rise of the supplement market. Um, there are studies out there that people have picked up these products, tested them to see if what is in there is really what is in there, and a lot of times what you think you're getting is not what you're getting, and they can't even identify what's in there. And because they're not a true drug, they don't actually have to have what they're saying that they have. But a lot of those products can be liver toxic. So, from my
Mhm.
standpoint, I don't recommend it because it's a safety issue. Um, we have medicines that can kind of help people out, and it's proven safety. They've been tested. We know what they do. That is we can't force you to do something, obviously, but from my standpoint, I think it's better to trust something that's been tested and it's been out on the market, and we know is safe. But um, I'm sure some of the products probably do work, but again, you just don't know what you're getting.
Thank you. So we had a couple of incontinence questions pre-submitted, or a few, I guess. Um, One, Dr. Bockholt, do you know what this one? Gentleman says his incontinence is worse at night and wonders if there's any reason for that.
Hmm.
Um, and then, so I guess we can address that first and get to the other
Sure.
ones.
Usually stress urinary incontinence is when there's some increase in pressure that results in people losing the urine. Most of the time, the patients are gonna, especially after prostatectomy, they're gonna be dry at night first and then slowly gain their control throughout the day because they're not moving a bunch at night. Sometimes if patients are having more leakage at night, there can be some other issues, especially maybe a fluid issue and not necessarily an anatomical issue. So in those patients, I'll sometimes do a voiding diary to find out when they're having accidents, how much fluid are they drinking, what's their bladder capacity, and then it can help me hone in on why they're leaking mainly at night, but that's definitely not the norm. Most of the people that are leaking because of incontinence due to prostatectomy or prostate surgery, it's during the day and they're usually dry at night.
You. Now, a gentleman asked, so been doing Kegels post-cancer treatment, and they've been helping. Am I going to have to do those forever to keep the benefit?
The best way I can describe that scenario is even bodybuilders, if you get to a certain strength, whether it's your bench press or squats, if you don't do some type of exercise, it's even hard to maintain. There has been some data that just doing, a few Kegel exercises multiple times a day where you're not really stressing the muscle can actually maintain your strength for a long time. So it's like men that are still having incontinence after a year, if you really put them on dedicated physical therapy and or Kegel regimens, you can get those guys drier. There used to be a thought that after a year, where you're at, it's kind of where you're going to be. That's not true. And if you want to maintain the continence that you've reached by being dedicated at doing faithful exercises, you got to continue to do some exercises periodically for maintenance.
Thank you. Question came in that asks, can both these surgeries, implants, be done? If so, is it at the same time, or if not, what order would you do them?
I've seen people do simultaneous. I don't do the slings and the AOS, so I wouldn't do it. But I mean, I have seen people do them. Obviously, it's going to be a longer procedure. I guess I don't know if that increases any risks or anything.
Well, and then Eugene, you should talk about these guys that are, maybe using one or two pads a day. What can happen after a penile prosthetic?
Yeah, you can get a little bit of improvement in urinary control. Those cylinders will add a little bit of pressure. So in people with mild incontinence, sometimes people will come back and say, "Hey, my incontinence has gotten better." So it's not for people who are severely incontinent, but if people are having just a little bit, I'm using one pad a day or something like that, you put an implant in, and sometimes you do see an improvement.
Mhm.
The final pre-submitted question we had was about testosterone replacement, and uh, I think this person might be assuming that they have low testosterone. And the question is, how likely is it that taking testosterone will restore my sex drive and my erections without any other sort of pill or intervention?
I'll give you my opinion. Testosterone, sexual function is kind of a complex event. The psychology has to be there, the nerves have to be there, the hormones have to be there, the blood supply.
Mhm.
What I tell people is testosterone is just one component to that. I have seen people where they have low testosterone, you give them testosterone and things are good. But I think too many people think that testosterone's kind of this wonder drug. And one of the reasons, I remember maybe 20 odd years ago, the pharmaceutical companies got in a lot of trouble because they were basically advertising, do you not feel like you're 18 anymore? Well, it might be because you have low T. Well, I mean, none of us are going to feel like we're 18 unless we're 18. I mean, it was a little bit misleading, and they actually got in a lot of trouble for that. I think it's possible, but it's more than likely. I think it's more of a multifactorial thing. There's usually several causes for these things, but yeah, there are some people who you get on testosterone and they feel a lot better and they do have improvement, but it's not just a one stop shop. Not every person is going to get better improvement with just testosterone.
Thank you. So I'm going to put a last call for questions in, and while we wait for those to come in, for both of you, what is the best way for a patient to contact you, find you, and see you if they'd like to?
Just calling us. If you just ask for us, you can. If you just say you're interested in these, there are people who in our office who do these types of procedures. If you just say, "Hey, I'm interested in the prosthetic," or "I'm interested in the incontinence type procedures," you'll find your way to the people who do these procedures. You can certainly ask for us by name, but you know, our office is equipped to be able to kind of get you to the right people.
Mhm. And if you have a relationship with your primary care doc, they simply send over a referral. And just like Dr. Park said, our schedulers know who does what case, and you should be able to get in to see the correct provider.
We got one more question that came in. Um, so, do patients on PDE5 inhibitors gain a tolerance to the medication over time?
I guess I never really thought about that. I don't know. I've seen people who've used it for years and years, and it works fine. I've seen people where it stops working, but I think the stopping working, the people where it stops working on, it's like maybe the diabetes got worse, or they're just getting older and things don't
They
work.
got older.
I don't know if I would say it's a tolerance per se. I just, as we all get older, things don't work quite as well. So I suspect it's probably more that than anything else.
And it looks like there's some dosage. Usually a daily dose of Cialis, it's a lower dose somebody's taking. So sometimes we'll switch patients to an on-demand dose that can be a little bit higher. And we see a number of patients that don't really take the Viagra or the Cialis correctly. They're either taking Viagra and waiting too long, or taking Cialis and expecting it to work right away. Um, and like the testosterone discussion, like Dr. Park was saying, Usually the erections are a blood supply and or a nerve problem where sex drive can be the testosterone issue. And depending on what a patient's testosterone is, sometimes you can get them to respond better to the pills if they have low testosterone and you help supplement it. So there's just a lot more tiers of discussion that happen to see if you can improve somebody's response to medication or provide them some different options.
Yeah, I think it's important to point out the oral medications, they don't give erections. They just help facilitate erections. So I always tell people you can't take the medicine and watch the news and think things are going to happen. You kind of have to have everything in place for it to work. It just kind of helps you get an erection.
And that last question, he's submitted twice. The issue is, like I talked before, the orgasm nerves are nowhere near where we do the prostate surgery and or radiation. So that's why guys without a prostate can still have an orgasm even though they don't have an erection. The discharge usually is very minimal because they don't have a prostate or seminal vesicles anymore. So where to start would be, meeting with the provider that can provide some other options, whether it's injections and or a prosthetic. Um, and seeing where you're at along with your cancer treatment course and where it'd be safe to provide a little bit more invasive options for the erection part.
You, Dr. Bockholt. So, wrapped up questions here. I want to open the floor up to both of you for any last um, comments or remarks you'd like to make to the audience here.
I'll start. The thing with any type of cancer surgery, whether it's like colon cancer, breast cancer, prostate cancer, the we're kind of torn between two things. We're trying to get maximal cancer control and maximal functional outcomes. And sometimes you have to sacrifice one to have the other, and vice versa, where the treatment options, they're never without risk. I do think there is all these percentages that we talked about earlier in our talks sometimes aren't sharing the patients that are actually seeking out options. So if it is really a huge hindrance to your quality of life, whether it's the incontinence or the erectile dysfunction, you're going to get the best options by just meeting with the physician. And that way you feel like all those stones have been overturned and you feel like there's no coulda, woulda, shouldas.
I just think, this is a very all of these things are very sensitive topics. They're very private. Some people find them just very embarrassing. I think people want to talk about these things, but don't necessarily bring them up sometimes for embarrassment. I would just encourage you to be open with whoever your providers are. We have all sorts of options for these problems, and we're more than happy to talk to you. You're not the first person to have these issues. You're not going to be the last person. We're not here to judge you for any of this, and we're here to help you out. So, just if you think you have a problem, you want to talk about it, we're more than happy to have an open discussion and just go over all these things with you guys.
Dr. Bockholt, Dr. Park, I want to thank both of you for your time this evening, for all the information you shared, and for your dedication to treating and educating your patients. For all of you who attended tonight, as Dr. Park said, these are not easy topics. I appreciate you taking that step forward, getting the information you need to empower yourself to treat these conditions. These doctors are available. We will send an email tomorrow with the phone number and contact information for the clinic. I hope you continue your men's health journey. Thank you all again. And final thank you to Dr. Park and Dr. Bockholt. This concludes our webinar this evening. Have a wonderful night.
Thank you.